Hello, everyone. This is hpch331. Sorry, I can't be with you in person on Thursday, 3:30, but I hope that you will get as much as you can, as much as possible out of this recorded session. What we will do is we will have the first part. I will go through slides and information about the fundamental cause theory. Unfortunately, we're not going to have interactions because I'm not with you in person / virtually. And then I'll take a break. I'll stop with the recording, and then I'll come back. Maybe this on Moodle. Maybe I will post two recordings. The first one will be the session, which is this one, and then second one will be a case study on tobacco smoking in Lebanon, which will feed into your third assignment that you're going to work on in pairs. And I have sent you an email basically providing some guidelines for the assignment and basically a list of each pair that will be working together. So let me share my slides. Let me share my screen right now and start. Okay. So as I mentioned, we will be talking about the fundamental causes of disease theory. And from my point of view, this is really a fundamental theory to understand and to grasp. And it really flows out of what we have been talking about since the beginning of the semester, which is this basic conceptual framework. And in this basic conceptual framework, as I mentioned multiple times already, there are, let me find my annotation, my flashlight, spotlight. Okay. So as I've mentioned a number of times before, this conceptual model or framework basically identifies two pathways that lead from social structural conditions and social position to health outcomes. The first pathway is the direct pathway, and it basically, I mean, the argument here is that social conditions have a direct impact on health. Where people live, the resources that people have access to, and other social structural positions that they encounter or that they are subjected to directly influence health outside any decisions or any actions that these individuals make. Then there's the other pathway, pathway number two, which basically argues that social positions also act on health through this pathway of behavior, whereby depending on a person's social structural position, that person's behavioral profile, whether it's smoking, it's healthy diet, it's physical activity, it's other behaviors as well. These behaviors then will influence health outcomes. However, the behaviors here are embedded or are an outcome of the social structural position. Okay, so that's the first model or conceptual framework that we talked about. This model, and I'm sure you've sensed my skepticism and um, sort of reservations about pathway number two, even though we spent a good part of the semester talking about psychosocial theories or behavioral theories that try to basically understand people's health outcomes through their behaviors, and then try to intervene by changing behaviors. We talked about this when we went over the Glanz and Bishop article and the principles basically of the main principles of the individual level behavioral approach. Here, in addition, to this, to the psychosocial behavioral approach limitations, in addition to that, we have other factors that conspire together to make us focus on our attention on these individual risk factors, which basically are the behaviors. So the first factor that is limiting our ability to understand the factors that contribute to health outcomes and disparities in health outcomes is basically the methods that we have, the epidemiological methods, and even some of the qualitative methods that we use that constrict our ability to really have a more complex view on the different factors, the social, structural, and the social networks, the behavioral factors, and how they impact health outcomes. So our methods are limited. And while epidemiological methods are developed and we have multi-level and structural equation modeling, which are very complex and difficult to work with, nonetheless, our methods continue to be limited in that regard. The other limitation that we have is that we also harbor cultural values. We harbor cultural values where we also put not necessarily the blame, but more the responsibility of health on individuals. This is a very Western concept, but it also infiltrates into our culture as well, where we generally think about health as an outcome of what people did in their life, what behaviors they adopted, what they know about health. We tend to basically harbor these cultural values. And what I'm trying to do in this course throughout is to move us away, slowly away from this line of thinking that it's about people's behavior only. And then, in order to improve health, what we need to do is raise awareness to change people's behavior. I'm trying to move us away from that line of thinking and to think about more distal factors and more structural factors that contribute both to behaviors and to health outcomes at the same time. Okay, now, the other thing that we talked about last week, just recently, again, in an effort to move away from a focus on individual behaviors, is that we discussed the importance of thinking about social networks and basically how the resources that people get or gain from the networks from the social networks that they are embedded in can, in fact, change or impact their behaviors and can impact their health outcomes. Again, similar to social structural conditions, social networks operate directly on health through a direct pathway, whereby, for example, people can get emotional support, instrumental support, even financial support through the social networks that they are embedded in. And those can have a direct impact on health. At the same time, the social networks that individuals are embedded in impact their behaviors. So, for example, you can think of like a simple example of adolescents who are embedded in a social network or who have a lot of peer or friends who smoke, for example. So in this case, the individual adolescent will be more likely to smoke because they are influenced by their social network. And that smoking behavior then will impact their health in the long term. So as we move away now from the behavioral perspective and then from the social networks perspective, and we get into the fundamental social causes of disease framework or perspective. And we'll try to go through this slowly. And in fact, we will go back to it. Next week, we don't have class because it's a holiday, but the week after, the session will be on the life course theory. And the life course theory is kind of an extension of the fundamental social cause. It's sort of like a longitudinal adaptation of the fundamental social cause. So we will come back to it. I'll try as much as possible today to go through some basic concepts and then we'll come back to them. And hopefully you'll explore some of these concepts in your assignment as well. Okay, so what we have here is we have the social conditions. The social conditions that in many cases people are born into. And these social conditions affect our ability to avoid disease. Um, Sometimes avoiding disease comes through behaviors, sometimes it comes through self efficacy. We're not denying that. However, we're saying that there are other ways that we avoid disease that are not only about our behaviors and our perceived behavioral control or our ability to control situations or self efficacy. There are fundamental social causes that really support us, that cushion us, and allow us to avoid disease and improve our health and well being. These, from a fundamental cause perspective, are access to money, power, knowledge. And knowledge here can be education, but it can also be bit broader than basically a person's level of education only. Although level of education is an important component of how much knowledge we gain in life and how and also our ability to utilize this knowledge. It's not only about education and knowledge itself, but it's also about the individual's ability to transform that knowledge into processes that protect their health as well. In addition to that, also prestige and connections. And those of us who, of course, who live in Lebanon and also elsewhere, if we think about some countries in Africa, uh, Algeria, of course, connections or what we call wasta, or our abilities to draw, our ability to draw social, I'm sorry, our ability to draw resources from our social relations are also very important from a fundamental social cause perspective. So a fundamental social cause is basically a resource. It's how much money the person has, it's how much power, it's their ability to translate knowledge into action to protect themselves, and also prestige and connections. And these factors help us avoid disease and improve our health and basically delay negative health outcomes. So, this is one of the pathways. One of the pathways in the fundamental social cause is providing individuals with this cushion or with this protection, with this shell, whether it's money, knowledge, prestige, connections. It's like a shell that helps an individual avoid negative health outcomes. Okay. So that's the first element of the fundamental social cause. The second element is basically that even if the individual is subjected or experiences poor health or disease, fundamental social causes support that person in their ability to reduce the impact of this disease even after it occurs. So the first pathway, I mean, if we want to think of them as pathways, the first pathway from fundamental social cause to health is basically that the fundamental social cause helps us avoid disease, so and improve health. So the second pathway is that even after a disease or poor health outcome happens, how much resources, access to money, power, knowledge, prestige, and connections, how much resources we have will help us reduce the impact of that disease, even if it occurs. So fundamental social causes help us avoid disease, but even if the disease happens, fundamental social causes provide us with more resources to reduce the impact of that disease. Okay, so a fundamental social cause of disease involves access to resources that can be used to avoid risks or to minimize the consequences of disease or risk once it occurs. It operates at these two levels. It prevents risk, and at the same time, it helps individuals minimize the consequences of this risk. The important thing about the fundamental social cause is that it's transferable from one situation to another. And this idea might seem a little bit strange. So let me say it again, and then I'll give you an example. A fundamental social cause of disease is transferable from one situation to another. Okay. Let's say we lived 100 years ago, where the main cause of mortality was tuberculosis or pneumonia or any other infectious disease that people got at a younger, at like in their 40s and 50s. And basically, this infectious disease led to their mortality. Tuberculosis is an infectious disease that is very much an outcome of living in crowded conditions where the infection is more readily or easily transmitted. In general, people who live in poverty are more likely to live in crowded conditions. And we know this until today, that people who live in poverty, people who live in displacement, live in crowded conditions. And these crowded conditions contribute to infectious disease in general. And 100 years ago, tuberculosis was the main cause of mortality. Nowadays, we're in the 21st century. Okay, the main causes of disease and mortality are cardiovascular disease and cancer, stroke and cancer. Now, unhealthy diet, in addition to smoking, in addition to physical inactivity, in addition to other behavioral factors, unhealthy diet is one of the main contributors to cardiovascular disease and in many cases to many types of cancer as well. Here, in many contexts around the world, including in our context, in a middle income, in what used to be a middle income country in Lebanon, poverty is an important factor in people's ability to eat healthy food, their ability to access basically access certain types of I mean, the public health nutrition students would know a lot more than I do, but diverse diet, for example, diet that has micronutrients, diet that has protein as well. Poverty is an important determinant of our ability to maintain a healthy diet. And this pathway or this behavioral, what we may call behavioral factor, eating an unhealthy diet, is basically the risk factor for one of the main risk factors for cardiovascular disease and cancer. Okay, so if we want to think about the fundamental cause, poverty here is a fundamental cause. 100 years ago, this fundamental cause manifested through crowding, through living in crowded conditions. And living in crowded conditions was the risk factor to tuberculosis, to an infectious disease health outcome. In 2021, poverty remains a fundamental cause of poor health. However, it continues to impact crowding as well. But if we want to think about the main causes of mortality nowadays, and one of the main behavioral risk factors, unhealthy diet, in 2021, basically poverty is operating through this risk factor of unhealthy diet. Okay. Okay. So the point to make here is that the pathway, which is crowdedness, 100 years ago, led to the poor health outcome of tuberculosis. In 2021, we have a different pathway, which is unhealthy diet, which is leading to cardiovascular disease and cancer, the leading causes of death in the 21st century. Even though the pathway, which is crowding and unhealthy diet, differs, and even though the health outcome or the cause of mortality differs, the main cause of mortality differs between 1920 and 20, between the year 1920 and the year 2021, despite the difference in the pathway and the health outcome, the fundamental social cause has not changed. The fundamental social cause has transformed um, the pathway and the health outcome, but it itself, the fundamental social cause, has not been transformed. It remained a fundamental cause of poor health, irrespective of whether the pathway is unhealthy diet or crowding, or whether the outcome is cardiovascular disease or tuberculosis. Okay. I'm pausing a little bit here so that you look at this figure or this slide and just think about it for a couple, maybe 20 seconds, not a couple of seconds, a couple of minutes. Okay. So there are two principles of the fundamental cause. The first one, and it has 2 points, but they are interrelated. The first principle of the fundamental cause is that the effects of the fundamental cause cannot be eliminated simply by addressing the mechanisms or the risk factors that link it with the disease. Let me go back to this slide. So the fundamental social cause approach says that we can work on unhealthy diet. We can provide information and knowledge and raise awareness about what is healthy and what a healthy diet is and how people should eat. We can do that. However, if we do not address the fundamental social cause itself, acting on the pathway, which is unhealthy diet, will not have a large impact on reducing the health outcome. So its effect cannot be eliminated simply by addressing the mechanisms. I will show you some examples, particularly the example of smoking, whereby if we do not address the fundamental social cause, it is very difficult to actually just work on the mechanism or the risk factor itself. So this is the first principle of the fundamental cause. Related to that is that the fundamental social cause affects multiple disease outcomes through multiple mechanisms. Again, the previous slide, poverty affects tuberculosis through crowdedness. Disease outcome number one, pathway number one. Tuberculosis is disease outcome number one. Crowdedness is pathway number one. Here, what we have, poverty. Disease outcome number two is cardiovascular disease. Pathway number two is unhealthy diet. So irrespective of what the pathway is or the disease outcome, what the disease outcome is, the fundamental social cause continues to operate. Okay, so it can affect multiple disease outcomes through multiple mechanisms. So the tuberculosis and cardiovascular disease is a temporal example. You know, what used to be the main cause of death 100 years ago and what the cause of death today. But let's think about health outcomes that we experience today. Diabetes and hypertension. Okay. The main cause of diabetes, of course, we're talking about behavioral, the behavioral main cause is unhealthy diet. Okay, of course there's the genetic, there are other physical activity and other factors, but let's just, for the sake of simplification, if we think about diabetes as the health outcome and unhealthy diet as the pathway or as the behavioral risk factor that leads to diabetes, the onset of diabetes. Then we have another health outcome, which is hypertension. Now you might be surprised that I put lead in water, exposure to lead in water. I could have put eating salty food or eating packaged preserved food. Maybe I should have done that actually. Okay, but it's very similar to unhealthy diet. So I wanted to pick another pathway. We will actually go over the relationship between exposure to lead in water and hypertension when we talk about the life course theory, because there's quite a bit of evidence on this relationship, exposure to lead in water in childhood and hypertension, the early onset of hypertension later on. Okay, so what we have here are two of basically health outcomes, chronic disease health outcomes, diabetes and hypertension. And we have two pathways, unhealthy diet leading to diabetes, also unhealthy diet leading to hypertension, but also there are other factors, exposure to lead in water. Living in poverty neighborhood is the fundamental social cause that leads to people's ability to access healthy diets. And also it is a fundamental social cause that contributes to children's exposure to lead in water or in paint or in water pipes, for example. Okay, so here what we have is a fundamental social cause that's operating through two different pathways and leading to two different negative health outcomes. In this case, diabetes and hypertension. So basically, this is this point here, that a fundamental cause affects multiple disease outcomes through multiple mechanisms. Okay. There's another principle which I'm very interested in myself, and it is less studied than the first principle because it's more difficult, in fact, and it requires what some people call natural experiments to basically try to, and really, really good data, of course, to try to basically measure and look at how this second principle of the fundamental cause operates. And this principle basically says that the impact of a fundamental cause becomes apparent under conditions of change. Okay, when we are going through conditions of change, then we start to see how the fundamental social causes are really, it's sort of like it's a filter that when you have changing conditions where some social groups become affected by that social condition a lot more than others because of basically fundamentally where they started out from. How much access to resources, financial power, knowledge, and social connections, how much access to these resources that people had under changing conditions determine basically the risk to health outcomes later on. Okay, so the impact of a fundamental cause becomes apparent under changing conditions. For example, the appearance of a new disease, a pandemic like COVID-19, shortly after the onset of the epidemic and the transmission worldwide, in many countries around the world, data started to come out showing that different people, different social groups are more at risk to the infection, but also more at risk to severe outcomes of the infection because of underlying risks, which I would call fundamental social causes. Okay, so COVID-19 is one example. We have other examples, such as the dissemination of knowledge about risk factors. So, for example, um, I'm not sure the dynamics, I'm not sure how the dynamics are in the context of Lebanon, but if we're talking about in the US, in the 1950s and 1960s, I'll give you the example about the US in a minute in the next slide, but I just want to quickly mention that the dissemination of knowledge about risk factors and basically having social groups, different social groups who have differential access to this knowledge and who have the ability to, different types of ability to utilize this knowledge to protect themselves, that the dissemination of knowledge, in fact, impacted people's ability to change their smoking behavior, and then later on, the risk to some cancers and also cardiovascular disease. Okay. Then the third example is the invention of a new treatment, whether that new treatment is a new drug or a vaccine, such as the COVID vaccine right now, right now, or the article that you've read about the HPV vaccine. There are other examples as well, such as the development of a new drug like statins, for example, or new treatment for breast cancer, for example. These are all factors that contribute to changing conditions that people are experiencing. And these changing conditions, in fact, highlight the impact of the fundamental cause on basically the distribution of the risk that different people or different social groups in society experience. Okay, so the prime example, and this may be more relevant to the context of the US or in Europe, for example, where if we go back 60 years ago, in the 1960s, tobacco advertisements, you might have seen some of this in your communication courses or in other undergraduates you've taken. Tobacco advertisements used to use doctors' testimonies to advertise their cigarettes. So for example, this one that shows that more doctors smoke Camel cigarettes than any other cigarettes. Because in the 1960s, in fact, doctors used to smoke. You used to go into a hospital and people used to smoke in a hospital. And doctors used to smoke. Actually, until very recently in Lebanon, I went into a clinic and the doctor was smoking in the clinic. But anyways, in the context of the US, in the 1960s, social groups with high levels of education smoked, because the knowledge about the association between tar or some of the other chemicals in cigarette smoking and lung cancer and the association between nicotine and hypertension and cardiovascular disease was not out there yet. In the mid 1960s, there was a Surgeon General report that basically laid out the results of research on nicotine and on tar and on other components of cigarettes, and established that cigarette smoking is a risk factor for lung cancer and cardiovascular disease. And as some of you who have taken epidemiology, you know that some of the we use some of the studies on case control studies in epidemiology to highlight, sorry, let me repeat that. We use case control studies on cigarette smoking and cancer as basically as teaching material in epidemiology courses about how how case control, basically you have your cases who are smokers and the controls who are non-smokers. And then you look at the outcome, and the outcome is basically the percentage of smokers who have lung cancer versus the percentage of non-smokers who have lung cancer. And basically this type of evidence established that smoking is a risk factor for lung cancer. Anyways, okay, but what do we see now? What we see now, and this is a graph I took from the internet from one of the studies. It's not very recent. It's actually from like 2010, basically, but also from the U.S. And it shows the disparities in smoking rates by education level. And you see here that among people who have graduate degrees or undergraduate degrees, the rates of smoking in the United States is pretty low. Okay, it's less than 5% if you want to take these two groups together, for example. It's around 5%. However, as level of education is lower, we're reading this graph from right to left. As the level of education decreases, you see that percentage of current smokers increases. And for people who have less than a high school education, you see a really high rate of smoking in the context of we're talking about the context of the US, where you have 36% or 37%, where you have 37% of those with less than high school education being current smokers. Thank you, shukran. Okay. Okay. I need to pause for a second. Okay, I'm back. Okay. So what happened here? What happened when in the 1960s, you had doctors who smoked and who actually were used in tobacco advertisements to basically entice people to smoke in 1960. And then if we look at 2010, we look at 50 years later, and we see this trend where you have people who have graduate degrees, only 4.2%, 4.1% of them are current smokers. Well, whereas those with less than high school education, 36.8% are current smokers. What happened is this trend that I will show you. Okay. And we can look at rich versus poor. We can look at high educated, people with high education, people with less than high school education, doctors, people with less than high school education. Before information, let's think that this is 1960 here. Before information about the harmful effects of smoking became public and disseminated widely, and before doctors basically looked at the evidence from research studies, basically everybody smoked at the same rate, whether the rich or the poor, whether the doctors or people with less than high school education. Information was not out yet, so nobody knew about the relationship between nicotine and cardiovascular disease, tar, and lung cancer. So people smoked because it was smoking was a trend, smoking was an expression of social status, was a way to socialize. Then what happened over time? Okay, forget about vaccine, new drug prevention strategy. What happened over time is that you had change. You had change in the context. And this change in the case of smoking was the fact that knowledge about the harmful effect of smoking became public. There was the Surgeon General's report on it that came out and was publicized very widely in the US media. The doctors started to talk to their patients in clinics about the harmful effects of smoking. So knowledge became disseminated. You can say it was a massive awareness campaign about smoking. What do you predict would happen at that point? Okay, if you were not exposed to the fundamental social cause of disease, you would think, oh, now everybody knows that smoking is bad and everybody will stop smoking. That's what anybody would predict. However, with our knowledge of the fundamental cause, and then later on looking at monitoring smoking rates and looking at data, what we see is that those who have resources, the rich or the educated, those who have knowledge, financial resources, prestige, and those who could basically utilize the knowledge, the information about smoking, individuals who could utilize the information about smoking to change their smoking behavior, changed over time. So over time, what you saw is that among the rich or the educated, the rates of smoking went down. And, they would plateau, I guess. They would reach a low level and would plateau. However, people who have less resources and have less education were not able to utilize that knowledge in the same way that people who had more resources and more knowledge. So their smoking rates, in fact, did not change over time. Okay. And this is what happens then when you look at it in the other graph here. This is a different way of showing that those who have higher level of education and higher knowledge were able to reduce their rates of smoking more than people who have lower level of education, which is basically an indication of financial resources, other types of resources, and also their ability to translate knowledge into mechanisms that protect their health. Okay, so this is a classic, from a fundamental point of view, this is a classic pictorial representation of what happens when a new innovation, whether that innovation is a drug, is a vaccine, or knowledge, new discovery about an association between one risk factor and health outcome. From a fundamental social cause, it is predicted that once this innovation is introduced, social change will happen, okay? And that change will lead to basically this disparity, this change in basically the risk profile, whereby the rich or people who have financial resources and knowledge would reduce the risk over time. On the other hand, those who are poor and who have lower levels of knowledge would not be able to utilize that knowledge to reduce their risk. Okay. There are multiple factors here. Maybe the knowledge is not readily available. The financial resources are not available. The perceived behavioral control or some like self-efficacy and control mechanisms are weaker among people who have manual jobs or who are poor or who have less knowledge. And that's why they have a lower level of ability to actually reduce their level of risk. Okay. So I'm going to just go over basically the key messages from the fundamental social cause. And then I will stop this recording and then start another recording, or maybe I will just pause and then go into the example of the HPV vaccine. So the key messages here from the fundamental social cause. The first one is never neglect fundamental social causes. So just as, you know, when we started out at the beginning of the semester, the key message was never to ignore context, the context in which the risk and the health outcome are embedded. Here again, never neglect the fundamental social causes in any research or any program that you are working on. Then the second key message is that even if you're study or if you're engaged in a project or a program where you are addressing risk factors, where you are basically trying to change people's smoking behavior or work with them to improve the quality of their diet or food, always contextualize the risk factors in the fundamental causes. Okay? Otherwise, any attempt to change the risk factors without paying attention to the social structural conditions that feed into that risk factor will be really difficult and futile in some cases. Okay, so let me pause here. And I will come back in a few minutes. Okay, but yeah, I'll pause the recording. Okay, I'm back. And I realized that I was the first part of the session was almost 1 hour. So let me go over the rest now and go over the basically some information about the human papillomavirus, HPV, and the HPV example, the article on HPV, which was a test of the fundamental social cause, particularly a test of the second principle of the fundamental social cause, which is more difficult, in fact, and requires access to really good data. Okay, so what is the story of the human papillomavirus? And how does it lend support, or the human papillomavirus vaccine, and how does it lend support to the fundamental cause of disease theory? For those of you who have time and who are interested in maybe in the summer, this would be a summer reading. I highly recommend this book. It's a very interesting book, and it touches on science, on ethics, on the United States history, on racism, everything. It's a very interesting book that is actually written by a journalist. The book is called The Immortal Life of Henrietta Lacks. And basically, Henrietta Lacks was a woman who had cervical cancer because she was infected with the human papillomavirus that developed into cervical cancer. Because she lived in poverty and she was exposed to this infection through sexual contact. And in fact, it's her cervical cells, cells that were taken from her cervix that were grown in labs in the US and in different parts of the world that are until today are used and sold and not used, I'm sorry, that basically these cells, scientists who work on cancer, who do cancer research, use Henrietta Lacks's cervical cancer cells. They were grown in a lab, and there was something special about these cells that they grew in a certain way that makes it feasible to do basically cancer research on these cells. So these are called HeLa cells, H-E-L-A, and they come from Henrietta Lacks because in fact the tube where these cells came from had the first two letters from her first name, and the 2 letters from her last name. Anyways, in an interesting book, I highly recommend if you want to read it on science and ethics and cervical cancer and HPV. Okay, so those of you who come from a life science background, maybe you know a little bit about the human papillomavirus and its relationship with cervical cancer, and that's the pap smear is usually done, basically to test. Women do the pap smear. I don't know if the recommendation was every year or if the recommendation changed, basically to see if there are any cancerous cells in the cervix. And the treatment for cervical cancer is, if it's detected early, it's highly treatable. However, in the early 2000s, a vaccine for HPV, the infection, was developed. And the idea behind that is that if the vaccine is given to adolescent girls in like 11, 12, 13, 14 years of age, then they would be protected from the HPV infection, from the virus, from the human papilloma virus. And if they are protected from this virus, then the risk of cervical cancer is much lower. Okay, so this vaccine did not exist before 2006. And before 2006, of course, there was no vaccine, so this statement is even silly that there's no difference between social classes and vaccination rate. There was definitely a difference in HPV infection between social classes and between racial groups in the United States, at least if we think about the United States. And of course, because HPV infection is related to poverty and exposure through sexual contact. Okay, so in 2006, the HPV vaccine became on the market. And you can think of the HPV vaccine as an innovation. It's just like the COVID-19 vaccine right now. It's an amazing innovation to develop a vaccine against a virus in the course of 1 year, okay, of research. HPV vaccine is also an innovation. It's like a new drug, new vaccine. It has many promises that it will basically prevent this infection and decrease cervical cancer rates. The trick about the HPV vaccine is that it's recommended to be administered in adolescents. So basically, the decision is made by the parent, not the adolescent. And the knowledge need to be acquired by the parent, and the convincing and the decision by the parents. So that's one of the tricky things about it. And there are actually a couple of studies on HPV, on the HPV vaccine in Lebanon and in the Arab region that have looked at basically cultural factors and if parents would agree with it, and also the cost factors as well. يمكن بعد شوي. Okay. 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 So my understanding from research in the region is that there are some cultural issues, but that cost of the vaccine is one of the main barriers to parents in the Arab region and in Lebanon to administer the vaccine to their children. But of course, there are cultural issues because the vaccine basically says that, the idea of the vaccine is that give your daughter a vaccine when she's 11 or 12, because if she becomes sexually active later, a few years later, then you're protecting her from this virus. And the parent is thinking, well, my daughter is not going to be sexually active. I'm not going to allow that to happen. So these are the cultural factors that are at play, in addition to the cost. So this is a really interesting study that I asked you to read, and the health public health nutrition maybe read the other interesting study on the access to food. And I apologize because these two studies, the human papillomavirus, used data from the United States, and the access to food, the fried chicken and green apples, who has access to fried chicken and who has access to fresh food. Both studies are in the US context. But again, I say that the fundamental social cause is a theory that requires sophisticated data to be able to study it and to understand it. But I think it applies in different contexts. It's just that we don't have the good data to be able to look at it. So this is the study on that has looked at social inequalities in adolescent human papillomavirus vaccination, and it tested the fundamental social cause theory. They used data from the United States National Immunization Survey team. This is a huge data set, and they used data from 2008, 2009, and 2010. And what they looked at is basically parents' knowledge of the vaccine, whether a physician recommended the vaccine, and whether there was uptake of the vaccine by parents. So I realize that the methods are complex and it's a long paper. I hope that at least you've read the top part, the literature review, because it's very interesting. It really summarizes the fundamental social cause theory really well, particularly the second principle of it. And I mean, if you've read the HPV article and didn't read the Phelan and Link article, I think you should be okay. You should have gotten enough information about the fundamental cause theory. So basically, these were their hypotheses that they listed at the beginning of their paper. But in fact, their hypotheses were proven. The data proved these hypotheses. So basically, what they found out is that lower SES and racial ethnic minority status adolescent girls had lower odds, their parents had lower odds of knowing about the vaccine. So the vaccine came out in 2006. And in fact, the pharmaceutical companies that developed the vaccine advertised it widely. And they advertised it with pediatricians, with family doctors. And there was a campaign where their family doctors and gynecologists and pediatricians were, how should I say this? We're kind of given incentives by the pharmaceutical company to almost push the vaccine on parents. The vaccine was not covered by insurance at that time. I'm not sure if it's covered right now. And I think it's 3 doses and it costs around $500. Okay, so there was wide dissemination of the vaccine after it came out in 2006. And what we are looking at here are data starting from 2008 to 2010. So in these 2 years or 3 or 4 years between the beginning of the dissemination of information about the vaccine and asking the health professionals to recommend it to parents, giving them lots of incentives to do so, what ended up happening in this short period of time, in like 2 years or 3 years? You saw what I actually showed you in this figure, that there was one group where their knowledge of the vaccine didn't change much, their uptake of the vaccine didn't change much, and there's another group that actually learned a lot more information about the vaccine. The doctor recommended it, and they basically give it to their adolescent daughters. Okay? So the study found that lower SES and racial ethnic minority status adolescent girls have lower odds of their parents knowing about the vaccine. So at the level of knowledge, the parents who have lower SES and African American and immigrant parents knew a lot less about the vaccine. Okay. Then parents who have lower socioeconomic status and of certain racial ethnic minority groups, particularly African Americans, they in fact had lower odds. They were less likely to receive health professionals' recommendation to vaccinate their adolescent daughter. And then finally, I mean, if the knowledge is lower, if the physician's recommendation is lower, then it was, I mean, it was logical to also see that parents who have lower socioeconomic status and who are from racial or ethnic minority backgrounds, in fact, vaccinated their daughters at a much lower rate compared to parents with higher socioeconomic status. Okay. So this is sort of like again, a natural experiment where you don't have a drug or a vaccine on the market, but then the vaccine is developed, okay, and it's out there. Then who is going to really benefit from its availability? People who have more resources, people who have more knowledge, and who have more access. I mean, in this case, the health professional's recommendation might be an outcome of access to health services, whether, you know, adolescent girls, parents are taking their adolescent girls for regular checkups, for example, with healthcare professionals. So people with less resources, whether they're financial resources, knowledge resources, access to health resources, and in this case, you know, the financial is important because the vaccine was not covered by insurance and it cost $500 at the beginning when it came out, then you immediately would start to see disparities or inequalities in who basically uptakes the vaccine and who doesn't. This is a very good example of, basically test of the fundamental cause theory. Another test is actually mammograms, because mammography, or this innovation, which is much, much older than the HPV vaccine. Again, when mammography became available, people started to see, I mean, not people, but researchers started to see inequalities in breast cancer, because some women had more access to mammography than other women, and those who had more access because of knowledge and resources and health insurance, then basically they could detect breast cancer earlier and survive breast cancer more or longer than women of lower socioeconomic status or less resources. Okay. I think I'm going to go ahead and not stop, but just to introduce you to the assignment. Okay. So I'm in the assignment, in the first question, I have two figures for you. This one here, and then this one. Oops. Okay. Maybe you didn't notice the difference now, but you will notice it in the assignment. And I would like you in your pair, the two of you, to discuss amongst yourselves, which one would you opt for? Which do you prefer as an outcome? Do you prefer to reduce the overall prevalence of a disease, even if the reduction is higher for the rich? So the blue here is the rich, and the red is the poor. Would you opt for something like this, where you would have an intervention here that would reduce the rates, but the reduction will be mainly among the rich? But it's a big reduction. See, it's a big reduction. Or would you opt for this, where you would introduce an intervention where the reduction in the negative health outcome will be less However, the gap between the rich and poor will be smaller. As you see here, the gap is getting bigger between the rich and the poor, but the decrease is more steep, the decrease in the negative health outcome. In this one, the gap is small, but the decrease is also small. So that's the first question in the assignment. The second question will ask you about a case study, cigarette smoking in Syria and Lebanon. And this is actually an article that I worked on with a colleague. And if we were meeting at the same time, I would ask you, do you think in Lebanon everybody smokes the same, whether they're rich or poor, whether they're educated or highly educated or not, whether men and women? And I've been in some classes where the students would say, yes, everybody smokes the same in Lebanon. Everybody smokes. It doesn't matter. I see very rich people smoking. I see highly educated people smoking. Women smoke at a higher rate. Okay. The only thing that is true is that Lebanese women smoke more, have higher rates of smoking than women in other Arab countries. Women smoke less than men in Lebanon, yes, but they smoke more than women in other Arab countries. And there are factors related to this that, you know, we predict what the factors might be. So we did a study, we looked at data, and I'm sorry, the data is a bit pathetic. It's from 2006 in Syria and 2004 in Lebanon, because we don't have more recent data. That's why I'm saying it's pathetic. But it's the data sets that had smoking, it has measures of socioeconomic status for men and women. That's the most recent data that we could access. So the objectives of the study was to utilize population level data to explore the social patterning of cigarette smoking among women, men and women in 4 Arab countries. We looked at Syria, Jordan, Lebanon, and Palestine. I only show you for your assignment the data for Syria and Lebanon. The hypothesis we had is that cigarette smoking is associated with social disadvantage. So we hypothesized that people who have lower SES will smoke more, even though there's a sort of like a cultural understanding that people in the Arab region just smoke. Everybody smokes. Okay. So we hypothesized that in all countries, low education and low wealth groups are more likely to smoke compared to high education and high wealth groups. So again, we looked at this data in Syria from 2006, in Lebanon from 2004. It's called the population, PAPFAM, the Population and Family National Data. Syria was 18,000 plus Lebanon was almost 10,000, the sample. And it's men and women. It has measures of cigarette smoking. It has good measures, actually. And it has level of education and wealth. In Syria, wealth is different than income. In Lebanon, because Lebanon is a middle income country, until recently, in studies, they used to collect data on income. In low income countries, they collect data on wealth, meaning they ask people, do you have a refrigerator? Do you have a car? Do you have a table? Do you have, what type of toilet do you have? So in low income countries, these assets constitute how much wealth the person has. In Lebanon, because 95, 99% of the population has a refrigerator, stove, even an air conditioner, even a washing machine. So they don't use wealth because it's not a good measure, but they ask people about their income. Now, there are problems with income. In all countries in the world, there are problems with measuring income, but particularly in Lebanon. And we also controlled for age, marital status, whether the person lives in rural, urban, and in Lebanon, we controlled for the region of residence. North, South, Bekaa, Beirut. Okay, so this is the data that you will look at. Okay. And this data shows you for Syrian men, This is the rate of smoking. The blue is the rate of smoking for men who have less than primary education. Okay, and then you go. The purple color is the smoking rate of men in Syria who have more than secondary education. Okay, you see for men in Syria who have less than primary education, 60% of them smoke. Only 35% of men who have more than secondary level education smoke in Syria. This is the data for women. You don't see much variability, and you see that smoking rates for women in Syria is low. So let's get to Lebanese men and women. Lebanese men with less than primary, why don't I have, I thought I had my spotlight. Lebanese men with less than primary education, the rate of smoking is 56%. Okay. Now, it goes down and down. And then if we think about Lebanese men with more than secondary education, only, I mean, I say only in relative terms, 27% of them smoke cigarettes, are current smokers. Lebanese woman is a bit challenging because you have this group in the middle here, which is Lebanese women who have primary education, who for some reason have the highest rate of smoking. But if you ignore, I don't mean to say ignore at all, yani I'm very detailed when it comes to data, but if you try to just sort of squint your eyes and look at the trend here, you see that rates of smoking are also lower, go down despite this peak, go down. And then Lebanese women who have more than secondary education, only 14% of them smoke. Okay. Now, I read the data for you for education. I read this data, kind of, I walked you through it. And I would like you yourself with your partner in pair to read the data for wealth. What does this mean here? What does this mean here? What does this mean for Lebanese men? Okay, the blue is the poor, the red is the middle income, and the green is the rich. And you see the different rates of smoking. How would you interpret that? And then here you have it for Lebanese women. Blue is poor, red is middle income, and green is rich. Okay, so I'm going to post the assignment, and the assignment will ask you some questions. These are not the questions that are asked in the assignment. I'm sorry, don't worry about these. But basically, there are a couple of questions in the assignment that ask you to describe the results, okay, and to explain these results through the fundamental social cause theory. Okay. By the time you watch this, the assignment will be posted, so don't worry about it. And the questions will be posted. And in addition to that, I would have sent you also an email by the time you watch this. I would have sent you an email on who you will work with in your assignment. And maybe I will expose all the email addresses so that you can email your partner, the person that you're supposed to work with, and just coordinate whether you want to meet on WhatsApp or whatever for like 50 minutes or to an hour to work on the assignment together. Okay, what I'll do is I don't want you to work with your friend. I want the public health nutrition to work with health promotion student. I want them male with female. We have 4 men. So yeah, I want to mix like that. And that's why I'm not just asking you to work with one other person. The other thing is that we have 13 students, so there's one person, it's an odd number. So I'll figure this out. Okay, so that's it. That's the end of the session today. Yeah, I mean, maybe I will not, of course, I will not tell you what the policy implications of the fundamental cause of disease is. But we will hopefully discuss it in 2 weeks when we talk about the life course, because as I mentioned earlier, the life course is really an extension of the fundamental cause, and we'll come back to this. It's really important to think about the policies and the practices and the policies um, that we need to start to think about as we move into the more structural, the theories that are more structural rather than psychosocial or behavioral. Okay, so thank you very much for listening. And I will stop the recording. And after this session, you will meet together and work on your assignment. In any case, the assignment is due on March 29th because I may not be able to get to it until March 29th. So if you want more time, you can have all the time you want. But if you meet with your partner and you finish all the answers and you feel comfortable, you can just upload it and you'll be done. Okay, thank you very much. So again, take care. These are difficult times in the country. And next week is Thursday is a holiday, so we will not meet. We will meet 2 Thursdays from today. Okay, bye.